Good morning. Looking beyond OCT biomarkers in retinal disorders. So, I'll be discussing the OCT biomarkers in diabetic macular edema, macular telangiectasia type 2, and drug-induced maculopathies. So, what is a biomarker? The National Institute of Health defines a biomarker as a quantifiable biological parameter that is measured and evaluated as an indicator of biological, pathogenic, or pharmacological response to a therapeutic intervention. So, OCT biomarkers in diabetic macular edema. So, when we deal with a patient with diabetic macular edema, we tend to see the OCT, see the thickness map, and decide the treatment protocols. So, here we are going to see about the OCT in detail and look for some biomarkers which can help us to predict the visual prognosis following our treatment. So, the role of OCT was first established in the prospective study with Lucentis for neovascular AMD to monitor intraretinal and subretinal fluid for treatment decisions. Later, various studies have used PRN approach based on OCT in the treatment of diabetic macular edema. First biomarker is DRIL or disorganization of retinal inner layers. It is the inability to distinguish between the ganglion cell layer and inner plexiform layer complex and inner nuclear layer and outer plexiform layer complex. It is measured at the central 1 millimeter retinal zone. It is DRIL is defined as the inability to distinguish at an area of more than 50% or more than 500 microns, which is considered significant, and it is associated with poor visual prognosis in eyes with edema or resolved edema. Greater DRIL at baseline is correlated with worse visual prognosis. An increase in DRIL during the 4 months period predicted a decline of visual acuity by 1 line. DRIL is also associated with increasing severity of diabetic retinopathy, especially proliferative diabetic retinopathy. Diabetic patients with DRIL have reduced retinal function compared with those without DRIL due to defective retinal lamination. Next biomarker is a hyperreflective retinal foci. It appears as intraretinal hyperreflective dots, represents subclinical lipoproteins that extravasate after breakdown of blood retinal barrier. It measures less than 30 microns. It is characterized by the absence of back shadowing and its reflectivity is similar to RNFL. It is an important imaging marker for inflammation. HRF present inside the retinal cyst or lining the cyst borders is termed as pearl necklace sign. Such a sign is seen in advanced DME, and patients with such a sign may be refractive to treatments. Greater number of HRF is present in patients with higher HbA1c levels, which reflects a more ischemic retinal environment. And such patients respond better with corticosteroid implants. So, among the anti-VEGF, faricimab performs better with patients with hyperreflective foci. So, with reference to follow-up, patients with higher number of hyperreflective foci are associated with early recurrence of diabetic macular edema and they require frequent follow-up. Next biomarker is the intraretinal cystoid spaces. Elevated VEGF levels affect the inner blood retinal barrier, leading to increased vascular permeability, resulting in extracellular fluid accumulation and cyst formation. They cause photoreceptor damage and affect the visual outcomes. Prognostic significance depends on the size, location, content, and its association with hyperreflective foci. Based on the size, cysts were classified as small, large, and giant cysts. Larger cysts are associated with macular ischemia and predict poor visual prognosis. Next, we see about the content. Hyperreflective signals within the cyst are associated with severe disruption of the blood retinal barrier. Fibrin and other inflammatory byproducts may fill these spaces and they respond poorly with anti-VEGF agents. Location of the cyst about the center and cyst with associated photoreceptor damage are associated with poor visual outcomes. Next biomarker is the presence of bridging retinal processes. They are usually seen between the cystic cavities. They are associated with improved visual acuity with treatment. They represent residual neural elements comprising of Muller cells and bipolar cells. Their absence of bridging retinal processes signifies poor prognosis post-treatment, and visual acuity is unlikely to improve despite resolution of cyst. Those patients usually end up in foveal atrophy and thinning. Next biomarker is the macular thickness. So increased macular thickness is due to intra and subretinal edema. Central subfield thickness is defined as the thickness of the central circle of 1 mm diameter in the circular ETDRS grid map. When the retinal thickness increases beyond the stretching capability of retina, it can lead to damage to bipolar axons, leading to suboptimal visual gain. It is important to consider that CST alone is not a good or reliable biomarker to indicate the visual prognosis. We have to always look for the other associated biomarkers. Next biomarker is a subfoveal choroidal thickness. Greater baseline choroidal thickness predicted better response to anti-VEGF. It is presumed to have patients with increased thickness have intact choriocapillaries, so lesser ischemia, so which explains the superior visual outcomes. Next biomarker is a subfoveal neurosensory detachment. Presence of baseline SRF was associated with better visual gains, and these patients respond better with corticosteroid implants. The very important indicator and biomarker is the integrity of ellipsoid zone and ELM. It is the most important biomarker. It is a direct indicator of photoreceptors and RPE health. Intact EZ have a better visual prognosis post-treatment. Long-standing DMEs leads to focal and diffuse loss of EZ showing suboptimal visual gain. Next is the vitreoretinal interface disorders. So they may be of two types, like anomalous PVD or the presence of taut posterior hyaloid membrane. They exert a tractional force and cause mechanical distortion, which is responsible for recalcitrant macular edema. Such patients benefit with surgical management like pars plana vitrectomy and removal of the taut hyaloid. So this is a summary of the OCT biomarkers. So negative biomarkers are presence of a hyperreflective foci and larger turbid and central intraretinal cystoid spaces. The presence of bridging retinal processes is a positive biomarker. Macular thickness, it's important to remember that it is not a good biomarker. We have to always look for the other associated markers. And for very important and biomarker is seeing for the EZ integrity. Next is the OCT in MACTIL. Macular telangiectasia was initially described by Gas and Okayawa. It is a disorder in which there is abnormality of the foveal or perifoveal capillaries associated with loss of outer nuclear layers and ellipsoid zone. There are three types, 1, 2 and 3. I will be discussing about the biomarkers in MACTIL type 2. This is a classification proposed by Gas and Blody. This is a OCT based classification. So earliest OCT finding is the enlargement of the foveal pit due to the thinning of retina temporal to fovea. It occurs due to the thinning of ONL and Henle fiber layer temporal to fovea. Hyporeflective cavities may appear located in both inner and outer neurosensory retina. So ILM drape sign occurs when a thin membrane overhangs a central cystoid lesion at the fovea. Disruption of the EZ zone and the ELM may occur. So loss of Muller cells in the perifoveal region may contribute to increased hyperreflectivity of middle retinal layers. It is a most frequent early OCT finding seen in the fellow eye of a MACTIL patient. Superficial intraretinal crystals may be present in all stages of the disease. And the very important biomarker is the presence of retinal pigment clumps, which may be an early indicator of biomarker to predict the onset of proliferative stage of the disease. So outward bending and dipping of inner retinal layers to the outer retina due to the collapsing of the inner retinal skeleton. Proliferative stage is a appearance of hyperreflective lesion in the subretinal space, and it can also extend to the choroidal underlying choroid. So poor predictors of visual acuity are foveal contour irregularity, outer turning of inner retinal layers, hyperreflective RPC and EZ loss. So summary, drug-induced maculopathies. So biomarkers, preclinical HCQ retinopathy, the biomarkers are parafoveal thinning, inner segment ellipsoid attenuation, flying saucer sign, moth-eaten appearance of the ISOS junction. So implementation of advanced retinal imaging tools has resulted in the development of strategies to decrease the likelihood of toxicity. Utilization of OCT biomarkers plays a crucial role in early detection of toxicity. Thank you.
Thank you, Juliana, for this such a detailed, informative session.